Hey everyone, welcome back. Imagine a clinical scenario. You have shifted an uneventful surgical patient from the OT into the post-op recovery room. In the recovery room, the patient was all stable, vitals are stable, yet suddenly starts vomiting. What do you give? We give her Ondansetron. So today we are going to discuss about the Ondansetron, which is a selective serotonin receptor antagonist. Why do we actually need to discuss about Ondansetron? What is the need? Because post-operative nausea vomiting is more distressing to the patient than pain. And the risk of it in general population is about 30% and in high-risk patients without prophylaxis is 80%, which is a huge number. Hence, the prophylactic anti-emetic must be given in high-risk patients. From this, we'll discuss about it later. Now, what is the mechanism of action? How does this drug work? It has two mechanisms of action. One in the center, in the central nervous system, it blocks the serotonin receptors at the chemoreceptor trigger zone, thereby inhibiting the vomiting reflex. And in the periphery, it inhibits the enterochromaffin cells of the gut release serotonin in response to the surgical stimulus. And this serotonin binds to the vagus nerve and that stimulates the vomiting reflex, which is inhibited by this receptor antagonistic drug. Now, this being a selective drug, we have no side effects like sedation, extrapyramidal side effects or dry mouth. Because other anti-emetic drugs which we use are histamine receptor blockers, dopamine receptor blockers and the muscarinic receptor blockers. Do name them in the comment section. Next, when do we need to give this drug? To give a good prophylaxis for the post-op nausea vomiting. For this, we need to know the pharmacokinetics of the drug. That is, when is the onset of the drug, when is its peak effect, and how much time, what is its half-life, how much time will it stay in the blood. The onset of drug, it can be given IV or orally. For the intravenous injection, the onset takes around 30 minutes. Peak onset of action, 60 to 90 minutes. And it stays in the drug. Its duration of action is from 4 to 8 hours on an average of 6 hours. So, for us to get the peak effect, we need the peak effect in the recovery room and the drug must start its action by the time the surgery ends. So, we have to administer the drug 30 minutes before the end of surgery. And so that its peak effect is maintained in the recovery room. Now, what is the dose of the drug to be administered? The dose preferably administered is 4 mg and 8 mg is the maximum dose that we can administer at once, and giving 4 mg is as effective as 8 mg. But the point is there is an increased risk of side effects with 8 mg, though therapeutically both have an equal benefit. Giving 4 mg is as equivalent as giving 8 mg. And for pediatric patients, it is dosed as 0.1 mg per kg IV and you can give a maximum dose of 4 mg to a pediatric patient. In special populations, this drug is metabolized in the liver by the CYP450 enzymes and excreted in the kidney after it is metabolized. So, in severe liver disease patients, the half-life increases drastically from about 4 to 8 hours to 20 hours. Hence, you need to be careful and maximum dose is 8 mg per day in severe liver disease patients. Now, what are the side effects of this drug? This drug is the safest but it is not risk-free. So, most common side effect is headache and dizziness. It causes constipation and the most serious side effect is QT prolongation. This can cause a dangerous heart rhythm called the torsidis T pointis, and this is more dreaded when You combine ondansetron with the volatile inhalational anesthetic agents and you give droperidol along with it. And the administration of the drug should always be given slowly. It should be given over 2 to 5 minutes IV. Why? So that the prolongation of QT, you are protecting the heart from a sudden change in rhythm. Now, we have seen what is the drug, what is the mechanism of action, where does it act, and what are its pharmacokinetics, its absorption, distribution, metabolism and excretion, and when we should be careful of it. Now, in whom should we give this drug? How do we know who is high risk patient? For this, we use the Apfel score. The Apfel score is a score to identify the high risk patient before induction. We have 4 points here: female, non-smoker, history of post-op nausea, vomiting or motion sickness in the past, and are you thinking of any post-op opioids for pain analgesia. These 4 points, each point has one point for each character is given. This is the score where we identify the risk of the patient based on this score. And then we give multimodal therapy for high risk patients. Who are high risk? More than 4. Where we give dexamethasone at the induction, ondansetron 30 minutes before end of surgery. Along with it, preferably give a propofol or in total intravenous anesthesia. Why? Because we have read already that inhalational anesthetic agents are also a cause for increasing risk of post-op nausea vomiting. Hence, giving this multimodal therapy reduces the risk of post-op nausea vomiting by around 50 to 60%. And in high-risk patients, monotherapy is not sufficient. We will discuss about the specific post-op nausea vomiting therapies. Monotherapy, when should be given, multi-therapy, when should we give, what are the other things we can do to prevent post-op nausea vomiting other than the drug administration in our coming videos. Now, like we have spoken in the clinical scenario, the patient is already vomiting. You consulted with the operating team and they have told that they have already given the ondansetron before. Now what will you do? You should not redose ondansetron within 6 hours because the receptors are saturated already. Instead, you will switch to other drug class like metoclopramide, which is a dopamine antagonist, promethazine, which is an antihistaminic, or you can give a propofol bolus also because propofol also has anti-emetic properties. Now this is what we have discussed there: dopamine, histamine and muscarinic receptors and their side effects compared to serotonin receptor. Now, so final pearls, it's safe to be given in pregnancy. It has been used as an off-label drug for hyperemesis gravidarum. It does not a prokinetics, that is, it does not increase the motility, so cannot be used for gastroparesis. For gastroparesis, you have to go for metoclopramide only. In drug interactions, this drug is most commonly given with tramadol because tramadol has a risk of vomiting. That's the most common and most distressing side effect of tramadol. And we give ondansetron before administering tramadol so as to reduce the side effect. But there is a drug interaction and it may reduce the analgesic efficacy of tramadol. Contraindications: should not be given with apomorphine because there is a risk of hypotension. Serotonin syndrome is a rare risk of serotonin syndrome, which is a more of like a theoretical risk when used in combination with other SSRIs or MAO inhibitors. Now this is the cheat sheet. Screenshot it for yourself and you are gonna give your best. Understanding the why will help you much better in remembering, and you don't need to just memorize the concept. Hence, if this helped you, hit subscribe and let's keep making complex medicine simple. This is Dr. MS Corpus. Stay curious and stay awesome.